So thanks everyone for coming along this evening, to everyone who's attending the meeting. My name's Alan. I'm a communications officer at the SDA in Victoria, and I'll be helping moderate tonight. So thanks for coming along to our information session with Dr Lena Rennick from the Department of Health and Human Services. We hope it's a useful session for you. Just a bit of, housekeeping. So the purpose of today is obviously for our members to be able to get some information and ask questions about the COVID-19 vaccinations, because obviously there's a lot of questions out there about the vaccines. So that's what today is about. Our industrial team and our information team have been answering lots of questions about how it affects your employment and those sorts of questions and government decisions. That's not what tonight's about. You're welcome to keep reaching out to us about that, and we'll keep answering those questions for people. But just to remind you what tonight's about so that we can make the best use of the time. In terms of the format, so there'll be a presentation and then time for some questions. You can use the Q&A function in Zoom. So if you go to the bottom of your screen, for most of you, you'll see a Q&A and you can ask questions there. We'll be able to pass those questions along and hopefully get them answered. So that's that. Michael, I might pass over to you to do an introduction.
Thanks, Alan. Well, I'd like to welcome the members to tonight's meeting. We set this up as a response to members who wanted more information about vaccination. And we're pleased that Dr Lena Rennick is able to address us tonight so that people can get reliable information about the COVID vaccination. Just briefly, and it's not medical information, just a story of interest. My personal story is I'm double vaccinated with AstraZeneca. I went to see my doctor because I wanted to just ask a few questions and satisfy myself before I was vaccinated. And so I did that, and I got the flu vaccination on the same day and booked in for my first COVID shot. Then I got my second shot a few weeks ago. So I'm about 3 weeks into it. That's a picture of me immediately afterwards. I didn't want to show you the one getting the injection. Some people are a bit squeamish. Mauro Moretta, the Assistant Secretary, he's vaccinated with the Pfizer vaccination. And it's just my personal story, but the big issue for me is I'm fairly comfortable now I'm vaccinated because I think it's a good protection about ending up in hospital or on a ventilator. So that's just my personal story. But I wanted the opportunity for you to get more information. And so with nothing further, I'll hand over to Dr. Lena. Thanks, Dr. Lena.
Hi, everyone. Just bear with me. I'm going to share my screen. All right. Hi, everyone. So my name's Lena Rennick. I'm a GP. I'm working in southeastern Melbourne. And similar to Michael, I've had my AstraZeneca shots. I've actually had both of my shots. That was way back in March and then and June for me. I got vaccinated to reduce risk of hospitalisation and death from COVID-19, to reduce transmission, and because I don't really like lockdown. And I've signed up to be a vaccination champion and do these webinars to people like you because I get a lot of joy out of educating my patients. And I'm also really passionate about science and how awesome vaccine technology is. And also I'm the kind of person where I think, oh, you know, this situation sucks, we're in lockdown. Well, what can I actually do about it? And maybe what I can do about it is talk to people. Okay, so just some important community messaging. So vaccines are just one layer in protecting against COVID-19. So you also need to make sure you keep doing all these other things that you probably all know very well by now, and getting tested when you have any of these symptoms. And getting tested as well as getting vaccinations, you don't need to have a Medicare card, and it is free for everyone. So I'd like to go through a little bit about vaccination development. But before I do that, you might have heard of two bodies that everyone says, oh, you know, ATAGI is saying this and the TGA is saying that. So I just wanted to define those. So the TGA is the Therapeutic Goods Administration. So this is a group of people that approve all pharmaceuticals in Australia following clinical trials. So they say what's safe and what's going to work. So that's the TGA. Whereas ATAGI, they're specific to immunisation. They're the group that give up-to-date evidence-based advice on who should get what vaccine and when. So a lot of people ask, you know, how do we know that these are safe? It's all happened so quickly. How do we know that it's going to be okay, you know, that corners weren't cut? Well, there's two main things that I need to say here. The first thing is that so many resources were thrown at this problem. We were in a world crisis. We had so many people's companies, research facilities offering money and equipment and teamwork to come up with a solution. So mostly it was the resources that we had to invest in the problem. But the other thing is no corners were cut. So as you can see, there are certain phases in making a vaccine. And because we had so many resources available, we were able to overlap. So we were able to make our time a bit more efficient, and we still completed every phase, but they overlapped, and that made it a lot quicker. Some people like to know about clinical trials, and I just wanted to say that, you know, the Pfizer trial has had 44,000 cases in it. The AstraZeneca trial has had 33,000 cases, and the Moderna trial has had 30,000 cases. So it's been in the clinical trials themselves, a lot of data has been gathered, and that's not to mention the real world data from the billions of doses that have been given around the world as well. Some people are a bit worried about mRNA technology. So just to reiterate, the technology has existed for a long time. We've known about mRNA since the 60s. We kind of figured out that it could be used for immunology in the 90s. And mRNA vaccines have been studied for things like the flu and Zika virus and rabies. So the technology was already there. We've just changed the virus that we're targeting. Okay, bear with me. I like to get a little bit nerdy because I think that when we understand how the body works, we're more likely to be comfortable with it and to be less anxious about it. So I just wanted to take you through the basics of the immune system. So the immune system has two phases when the body detects an invader. So the body detects an invader and there's an initial attack with defense cells. So these are white cells and the body chemicals like cytokines. So these are just some big words to say what happens. You end up getting a fever, you get some pain, you get inflammation, and that's how symptoms work from infections. But then the really cool thing that the body does is form a memory of that infection, and it teaches the body how to fight the invader if we ever see it again. So vaccinations show the immune system an imposter of the bug to teach it a plan of attack. So these little things, they're called spike proteins. I like to call them tulips. What the vaccines have done is given our body the DNA, the genetic code to reproduce these spike proteins, because that's the invader that the body recognizes as foreign. So the Pfizer and Moderna vaccine do it through mRNA. You might have heard that term. That's messenger RNA, so genetic code that tells our body to make proteins. And AstraZeneca does that through putting the genetic code into another virus that is innocuous, that doesn't hurt us, but just is another way of delivering that genetic code. So mRNA, once the mRNA enters the body's cells, the cells use the instructions to make the spike protein, which is that tulip-looking thing. And the immune cells then learn to recognize the spike protein as foreign and build an immune response against it. And for the AstraZeneca vaccine, it's an adenovirus. That's the virus that causes the common cold that's used. This vaccine technology has also been used for Ebola, so we know it works. And similar to the mRNA vaccines, it gives a genetic code that tells the body how to fight that spike protein. So the body learns to recognize the virus without the actual virus ever having entered your body, which I think is really, really cool. The other thing is the body breaks down the genetic material within a few days. All that's left is the immune system memory. So this is one of the reasons that we can be really confident that there aren't really long-term side effects, because it's just the body's memory that provides protection. It's not any of the ingredients in the actual vaccination. And the vaccination doesn't change your DNA. So the spike protein code is just another thing that's entering the cells. It never comes near the nucleus of the cell where the DNA is kept. So in a cell, the nucleus houses the DNA, and the vaccination doesn't go anywhere near that. The vaccination is just training the immune system. Okay, that's the heavy science stuff out of the way. Let's move on to a bit more about eligibility. So everyone age 12 years and over now can get a vaccination. So the question is, which one are you going to get? So the three questions that I would ask my patients if they came in and asked me which one should I get, I would, say, okay, how old are you? What medical conditions do you have? And do the benefits outweigh the risks of AstraZeneca in people under the age of 60 compared to getting a Pfizer or Moderna? So a bit about each of the vaccines. The AstraZeneca, that's the viral vector vaccine. That one's offered to 60 years and older, but also ages 18 plus, who we think that it's going to take them too long to get Pfizer or Moderna. And so I'll go through it later. Once we weigh up the risks and benefits of the clotting syndrome that you might have heard about in the news, we might say, yeah, AstraZeneca is a good option for you. And you can get that from your GP and from state centres. The Pfizer vaccine, that's offered to people 12 plus. It used to be restricted to 12 to 60 only, and now the 60 plus age group can get it as well. And the Moderna is very similar. It's also offered to people aged 12 plus, and it's also available in pharmacies. The pharmacies are doing the main rollout of the Moderna vaccine. So to book an appointment at the state vaccination clinic, take a quick screenshot there, 1-800-675-398, and you can use the eligibility checker as well. Okay. So this is a bit about the mRNA vaccine for people aged 60 years and over. So that was just an announcement a couple of weeks ago, just saying that, that the 60 plus age group can get mRNA vaccines. Second doses, there has been a bit of a change around, and it's been a bit confusing saying, should it be 3 weeks or 6 weeks or 12 weeks between doses? Well, the current thinking is that Pfizer is 3 weeks, Moderna is 4 weeks, and AstraZeneca is 6 weeks. And the way that they've calculated those numbers is how are they going to get as many first doses and second doses in arms, and making the efficiency of vaccination the most beneficial. Some people ask about boosters. My reply to that would be, don't worry about it yet. Let's just focus on dose 1 and dose 2. ATAGI, that immunisation body, have said there's insufficient evidence. But if we look overseas, we can see that in the UK and the US, they are going to be doing booster doses. Just watch this space for boosters. And people who are immunocompromised, so if you have a condition that makes you predisposed to certain infections, or if you're on any immunosuppressant medications, you can get a third dose of the Pfizer or Moderna, one of the mRNA vaccines, to 6 months post your second dose. There are reserved appointments for people who are at high risk. So if you think you're at high risk of getting COVID-19, you can get a vaccination sooner by calling the hotline. So that number's there again on the screen. As I said earlier, you can get a vaccination even if you don't have a Medicare card. So you can register for an individual health identifier, an IHI, but this is preferred, not mandatory. So you don't have to do that. But essentially, it's a number that'll help for healthcare purposes so that health professionals make sure the information that they attach to the patient is you. And then it also will help you get your proof of vaccination because you can get a My Health record, which is an online summary of your health history. Adverse effects. Okay. So many questions about adverse effects, and I get so many questions in my practice as a GP about adverse effects, but most of them are so minor. So about 44% of people will get an adverse effect of some kind. So mostly that's injection site pain and fevers and muscle body aches and things like that. And that's because of that initial immune system response, that invasion process where the immune system first fights infection. The important thing to note is that only 0.8% of people reported visiting a doctor or an emergency department with an adverse effect. So it's unlikely to be serious. If you do have a Medicare card, most GPs are going to bulk bill a consult for an adverse effect if you need it. So if you are worried about it, there's help out there. We're not gonna leave you stranded on that. Okay, we need to talk about AstraZeneca and blood clots because that's been all over the media and there's been a lot of misinformation. So AstraZeneca is associated with a very rare condition called thrombocytopenia syndrome, thrombosis with thrombocytopenia syndrome. Okay, it's a clotting disorder in the brain and the abdomen followed by bleeding. What's happening is the immune system is causing this clotting, and then the body runs out of the ingredients it needs to make a clot, and that's what leads to bleeding. The symptoms start mostly between days 4 and 20 after the vaccination, and I've listed them there. Headache, neurological symptoms, shortness of breath, chest pain, swelling in the leg, persistent abdo pain, and tiny spots under the skin away from the site of injection. Okay, if you do have any of these symptoms, go to hospital, because it can be treated effectively. Early diagnosis and treatment significantly improves patient outcomes. A lot of people are worried that they have a history of other clotting like pulmonary embolism or deep vein thrombosis or other vascular things like varicose veins. This isn't relevant for the AstraZeneca blood clotting. So these are the questions that we'll ask you on the consent form. So these things: capillary leak syndrome, TTS, cerebral venous sinus thrombosis, heparin-induced thrombocytopenia. They're all really long words and things that we don't expect you to know unless you've been given a diagnosis of it. So if a doctor hasn't told you that you have any of these things, the AstraZeneca can still be considered for you. The other thing, I don't actually have a slide on it, but I just wanted to touch on, is that the reason that you get TTS from AstraZeneca is because the immune system is doing its job. COVID itself is more likely, I think 4 times more likely to cause TTS than the vaccination itself. So if you're really, really worried about TTS, this clotting syndrome, the vaccine is a less likely way to get it than to get COVID itself. I hope that makes sense. And that's similar for the heart inflammation for Pfizer and Moderna. So Pfizer and Moderna, the mRNA vaccines, can cause inflammation around the heart, known as myocarditis or pericarditis. The things to watch for in the first 1 to 5 days are chest pain, shortness of breath, irregular heartbeat, pain with breathing, fainting, seek medical attention because treatment is readily available. Most people don't even need hospitalisation for any of this. So if you have a pre-existing heart condition, check with your doctor. And these are the things that we ask for in the consent. So if you've ever had myocarditis or pericarditis, and we're only worried about it if you've had it in the last 6 months. The other thing are acute rheumatic fever, endocarditis, congenital heart disease, dilated cardiomyopathy, or severe heart failure, or recipient of a heart transplant. So those, the really common heart disease that people get is like ischemic heart disease or heart attacks or valve problems. That doesn't matter with the Pfizer or Moderna vaccines. What about the long-term effects of vaccinations? This is the hardest question that I get asked because I can't predict the future, but this is my answer for you. Science is giving us the best answer that we can for this question. The first thing that we need to remember is that the vaccine is broken down by the body in a matter of days, and it's only our natural immune response that lasts. So the ingredients of the vaccination aren't lingering around in your body. Also, we know science dating back to 1961 with the polio vaccine tells us that any adverse effect occurs within 3 to 4 months of vaccination. But also we need to weigh up the risks and benefits of getting a COVID vaccine versus getting COVID. And we are unfortunately still really deep in really high case numbers, and especially with the Delta variant. So I'll just touch on the Delta variant. The Delta variant, it's the name given to the how the virus has evolved. So similar how we get different strains of the flu every year and we get a different flu vaccine, the coronavirus has evolved, and the scientists are naming that after Greek letters. So the one that we've got is Delta. It came from India. And it is 5 to 6 times more likely to transmit between people. The Delta variant gives us an increased risk of hospitalisation, but the AstraZeneca, Pfizer and Moderna vaccines are all really good at protecting against severe disease and hospitalisation and death from COVID-19 Delta variant. So that's these numbers down here. So we'll just go through those a little bit. The Pfizer vaccine, 96% against hospitalisation for Delta variant. Moderna, 81%. AstraZeneca, 92%. A few special groups. So fertility. COVID vaccines have no effect on fertility. Women who are trying to become pregnant don't need to delay vaccination or avoid becoming pregnant after vaccination. I myself am contemplating pregnancy in the next couple of years, and I had no problems with getting the AstraZeneca vaccine. There are some myths associated with fertility. So one of them is that the spike protein looks the same as a syntysin 1 protein. So the syntysin 1 protein is one that's on the placenta. So people think that because the proteins are kind of the same, it'll cause infertility. But it's like comparing apples and oranges. They're both fruit, they're both proteins, but they're still really, really different, and they're not going to influence each other. If you're after the number, they have a 0.7% similarity, so very, very low. The other thing is that vaccinations can't be, causes viral shedding, so can't be used in pregnancy. Well, COVID vaccinations are not live vaccines. You might have heard of live vaccines. That's like the measles, mumps, rubella vaccine. And those ones that you're not supposed to get in pregnancy, but COVID vaccines, that doesn't apply. Pregnant women should be routinely offered Pfizer at any stage of pregnancy. There's no safety concerns for the woman or her baby from the Pfizer vaccine, and it helps to protect her against COVID-19 infection. I guess earlier on in the year when we were first talking about vaccinations, we didn't really know. The first clinical trials didn't include pregnant women. So at the time, and you can imagine why that, because your first initial clinical trials, you don't want to use one of the most vulnerable populations. But real world data has come out, and we now know that the Pfizer vaccine is safe in women, efficient in women, and even you can transmit some antibodies onto baby, so it can even protect baby as well. We also really want pregnant women to get vaccinated because pregnant women are more vulnerable at severe disease. They're more likely to need admission, ICU admission, and breathing life support. There's also risks to her baby if the pregnant mum gets COVID, including increased prematurity, increased need for admission to the newborn care unit. So the newborn is at risk as well if mum gets COVID. So we want pregnant mums to be getting vaccinated with Pfizer. And also, it's safe to continue breastfeeding before or after COVID vaccination. There's no evidence of harm to the woman or her infant. The only side effect that might occur is a slight decrease in milk supply for about 24 hours. But if anyone is breastfeeding, they'll know that's okay. It only occurs in about 5% of individuals, and your supply comes straight back. Children aged 12 to 15 years are being recommended the Pfizer and Moderna vaccines. These vaccines are even more efficacious in children than in adults. It's well tolerated, children have less side effects, and there's a similar risk of myocarditis compared to older age groups. So that some people have thought that children are more at risk of these heart inflammation, but that's not true. And children 6 months to 12 years, well, we don't have a vaccination for them yet. Watch this space, it is coming. So the way that we protect them is by vaccinating all household contacts, all their teachers, all the people that they're going to come in contact with, and washing our hands and scanning QR codes and all of that. A note on vaccines and faith. So COVID vaccines are halal. They're supported by a huge range of faiths and religious leaders globally, and they don't contain any human or animal tissues or cells. I have a sister-in-law actually who's vegan, and so I've looked into this in quite a lot of detail, and it is okay for people who are vegan to get vaccinated, and also people who are anti-abortion. The cell lines that have been used to create these vaccines don't actually contain fresh fetal tissues from aborted fetuses. So if that is your stance on abortion, the vaccines are still okay for you. And finally, we'll be looking at how to access your immunisation record. So, Dan Andrews has said that it's going to be essential that we have proof of our vaccination. So we'll need a COVID-19 digital certificate or an immunisation history statement. They're super easy to get. I've actually made some screenshots here. So you go to this website, the Australian Immunisation Register. You click on how to get an immunisation history or statement, and then it'll take you to either a Medicare app or a MyGov website. Medicare is super easy. I've got it on my phone. I've added it to my digital wallet on my iPhone, so it now comes up like a bank card. I have my my COVID vaccine passport essentially on my phone, and you can get a like a PDF version of that on the MyGov website. And you can set up MyGov even if you don't have Medicare. So these are the resources that have been used in creation of this presentation. You can take a screenshot there if you like. There's so much out there to read. The good places to go are government websites and the Victorian government website and the Australian government website as well. The last thing I wanted to say is that more than 5 billion doses of vaccines have already been given. So jump on board and get vaccinated. And thank you for listening.
Thank you, Dr. Lena. That was a great presentation. We've had a fair few questions come through. So just a reminder to everyone that you can use the Q&A function in Zoom to send through questions. One of the questions we have is if the vaccines are safe and tested, why has the recommended vaccine type for age groups changed so many times?
Yeah, that's a really good question. And that's actually something I'm really passionate about. So the really cool thing about science is that we keep up to date. So we'd actually be worried if we found new data and we gave all these doses and we found out this information and the recommendations didn't change. So we might think that there's been a lot of changes in the past year, but if you think about it, it's just because we've given 5 billion doses. So for example, when I counsel parents on vaccinating their children, you know, their 2-month-old, 12-month-old, 18-month-old, those recommendations have changed heaps over the past decades. It all comes out with more experience and more data. So it's actually really reassuring that the data has changed. It just means that we're keeping up to date. And those bodies, the ATAGI, they're a group of professionals that are right on top of all the data and all the changes that, you know, we see in our GP clinic and how we practice. We're listening to ATAGI. We're doing what ATAGI tells us. There was a bit of confusion earlier in the year about what the politicians were saying versus what ATAGI was saying. But doctors and state hubs, they go off what ATAGI is saying.
Great. Another question we had is there a particular risk for people with angina?
No, so angina is a form of ischemic heart disease where people get chest pain because of constriction of their blood vessels, and it reduces oxygen supply to the heart tissue. So that hasn't got anything to do with inflammation of the heart. It's more to do with the blood vessels, the coronary arteries. It's a form of ischemic heart disease rather than inflammatory heart disease. So no.
A question from someone who's been double vaxxed with AstraZeneca.
Mm-hmm.
It's on boosters, which I know you said there's a bit more information coming later on. They've asked, will I need a second mRNA within 3 weeks of having it for the first time for it to have full effect? Or does the immunity from AstraZeneca work with the mRNA booster?
Yeah, so both the AstraZeneca and the Pfizer and the Moderna are teaching the body how to recognize that TULIP, that spike protein. So even if you've had 2 AstraZenecas for your first shots, which I've had, your booster shot, which I think is looking like is going to be a Pfizer or a Moderna, you'll only need 1 booster because it's still working on the same way of making the body recognize the spike protein and forming that memory in the immune system.
Great. Another question, aren't the vaccines still in clinical trials until 2023? How do we know that there are no long-term effects of this vaccine? If there are no long-term effects, why won't the manufacturers offer some sort of guarantee?
Okay. That's a sort of question that I've tried to answer by saying, how do we know there are no long-term side effects? No one's going to give you a guarantee on anything because legally they're not going to do that, because if something happens, they're at a huge loss. But the thing is that we use science to predict the future, and the manufacturing companies aren't the scientists. They're the people worried about their own kind of legalities of things. Okay. And if we look at the science, we can see that, you know, the vaccine is broken down in the body within a couple of days. The ingredients of the vaccine are no longer there. It's just the immune system response. So that's one of the reasons that we can be confident. And also we look back in history and we look at how other vaccines have played out, And when we studied the polio vaccine in the 60s, the adverse effects all came out within the first 3 to 4 months. And we've been giving these vaccines now since, in Australia since March, but all over the world since well before that. So we as doctors and ATAGI honestly believe that there aren't going to be long-term side effects.
A question here from someone whose partner has told them that they can't get vaccinated, but they want to. What sort of options do they have accessing a vaccine safely?
Okay, so you can still go back to those 3 questions. What's your age, and what medical conditions do you have, and whether the risks and benefits outweigh, how the risks and benefits weigh up for AstraZeneca. So regardless of whether your partner or not is vaccinated, you can get whichever one you like. The thing I would say though is that, I mean, to be as safe as you can with that, you still can transmit COVID-19 even if you still can contract COVID-19 even if you are vaccinated. So if your partner is unvaccinated and is bringing it home, that's putting you at risk, and you're at less risk of getting severe disease and needing hospitalization and dying, but you still are at some risk. So if you can have a conversation with your partner, I think that would be your best bet. Don't worry so much on which vaccine, just get a vaccine.
Great. Another question we've had is someone's heard that the Novavax vaccine is coming and that's a better and safer vaccine. Is that correct, and should they wait to get the Novavax vaccine?
Okay, so I've done my online COVID-19 training on Moderna, Pfizer and AstraZeneca, and there isn't any Novavax training available yet. So I know very, very little about Novavax. What I would say is a comment on the pandemic and say the sooner you get vaccinated, the better. If you end up getting COVID-19, once you have an infection, you have to wait another up to 6 months to get vaccinated. So it could be a really long time until you get vaccinated if you do choose to wait.
Yeah. Does the vaccine affect you if you have high cholesterol? Is that an issue?
No, so that's similar to an angina question. So high cholesterol can lead to angina, and high cholesterol isn't related to the vaccination.
Another question here. Why do we have to sign a consent form for this vaccine when we don't have to sign for any other vaccine? Why is this one different?
That's probably a legal question rather than a medical question, and not one I know the answer to. I suspect it's probably got to do with the manufacturer's requirements. Yeah.
Question here. Why have some other countries suspended use of the Moderna and AstraZeneca vaccines?
Oh, I wasn't aware of that. Which countries were those?
I'm not too sure from this question, but I suppose what you've presented is the Sweden, someone said.
Okay, I've only been trained in what's going on in Australia. I mean, it's hard enough keeping on top of Victoria, let alone the rest of the world. So sorry, I don't know the answer to that.
Yeah. Question, was the vaccine tested against all medications? I suppose if you're taking medications, you have to be concerned about getting vaccinated.
No. So you can't test the vaccination against all medications, but we know how vaccinations work with the immune system. So like medical science tells us the only things that interfere are immunosuppressants. So if you're on something for an autoimmune condition, like Crohn's disease, or if you have rheumatoid arthritis, or specific conditions where you'd be seeing a specialist, and if you were on immunosuppressants, you would know that it was an immunosuppressant. They're the only ones that we worry about.
Yeah. some of these questions, I think you covered in your presentation, but I think it's worth putting them back to reassure some people and have them asked again. Someone's worried that it's an experimental vaccine and not tested enough until 2023. I guess what would you say in response to that sort of question?
Yeah, so I go back to that kind of bar graph infographic that I had that showed the different stages of vaccine development, and say that that no corners were cut. We still met all the standards. I can't remember off the top of my head, I had it written down, but AstraZeneca was like 44,000, Pfizer was 30,000 people in their clinical trials. So the trials were sufficiently big enough. We just continue studying it because we like as much data as we can, and we actually have the money and the resources to keep studying it. So no corners were cut. It was just overlapped because we had so many resources and we were in crisis, global pandemic.
Question here. So can I share the link with family and friends to try and convince them to take a vaccination and remove their fears? I think in the presentation there are a few resources there that you could go to and share with your family and friends. And on our end, we're also looking at taking some, I guess, some frequently asked questions that we receive, and also from this presentation, and putting together some information for union members as well. So we'll try and get that information out. But all those links are there in the presentation for you to use.
So I can create a PDF copy of my PowerPoint slides and send that to you.
That would be great.
Yep.
How can they advise that it's safe in pregnant women when they don't have the data to prove the baby will be okay? And part two, why have I never met anyone with COVID but know at least 10 people with serious reactions to the Pfizer vaccine?
Okay. All right, let's take one at a time. And knowing me, my fish brain memory, I'll answer the first one and forget the second one, so you might have to prompt me. So the first question is about how do we not know that it doesn't severely affect the newborn? Well, real world data has actually come out where the Pfizer vaccination has been given to pregnant women and it hasn't adversely affected the newborn. And what they've actually found is that the newborn gets some of the antibodies through the placenta. So the placenta is how mum's blood supply gets into baby through the umbilical cord, like where your belly button is. And so that's how baby gets nutrients, and it can get antibodies, so the immune memory against COVID, so that it has some protection when it's already born. And what they've actually found is that pregnant women who do get COVID, their babies are more likely to go into the neonatal intensive care unit, need resuscitation. They're more likely to be premature. So it's actually harmful to get COVID and not harmful to get the vaccination. If you actually think about other vaccinations that they give in pregnancy, so we recommend all pregnant women get influenza vaccine, so the normal flu vaccine. We recommend that women get whooping cough vaccine. It's a similar thing. It's where we're saying that if we vaccinate mum, we're actually helping baby, we're not harming baby. And the second question was, how come I've never met anyone with COVID? You know, I actually asked myself the same question as this earlier, and it wasn't until about a month ago that my cousin in Shepparton got COVID, and she was the first person I'd known in this whole pandemic that had got COVID. And honestly, I don't know how it happens that it took that long because of the cases that we've had, but there are millions of people in Melbourne, and so sometimes statistically it doesn't add up, but more people are getting vaccinated every day, and we're more likely to hear the negative stories of side effects than we are to hear the good things. So people very readily will say, I got this reaction, I got that reaction, watch out for this, watch out for that, unless people are, putting on social media, I got my vaccination and it was uneventful.
We've probably got 5 more
minutes for questions, everyone. So we'll just keep going through. I think you might have touched on this as well, but do you shred the virus when you get vaccinated? And would that be why the cases are going up due to higher vaccination rates?
Oh, no, absolutely not. Absolutely not. So viral shedding happens when you give someone a live vaccine. So that's like the measles, mumps, rubella vaccine. And that's when you give someone, it's called live attenuated. So it's a live vaccine that's been modified a little bit so that it doesn't make you sick. But it's giving you the vaccine so that you then remember it rather than the genetic code so that you create the imposter so that you then get the memory to it. So viral shedding only happens with live vaccines. So that doesn't happen with the COVID vaccine. The reason that we've got increased cases at the moment is because it's exponential in growth in terms of how cases work. Every person who gets COVID is likely to spread it to 5 to 6 people. So as you would math, I haven't done math since grade 12, but you know, the curves that go like this, exponentially it gets bigger, and that's why our numbers have gone up. There's just the Delta variant is more likely to spread from person to person.
Great. If you've had COVID, does that give you immunity, or do those who've had COVID still need the vaccine?
People who have had COVID should get their vaccines 6 months after they've had their initial infection.
I think we've covered that one. Why are there so many doctors and nurses refusing to get it if we should trust the science? It's from someone.
I don't believe that that's particularly true. I would say that the majority of doctors and nurses have all been vaccinated, not only because we understand the science and we want to get back to work and we feel scared going to work and being on the front line, but also we trust that it's gonna work, and we're probably mandated to by our organisation. I think maybe the ones that you're hearing about, the nurses and doctors who are refusing, that might be, I'm just taking a guess, an extrapolation of social media or misinformation.
Yeah. Something else you've touched on slightly, but why are case numbers getting so high when the vaccination rate is also going up? You know, how can those two things happen at the same time?
Look, that's honestly a question for an epidemiologist rather than a GP. And I don't know exactly the answer, but it's because when we haven't reached that herd immunity yet. So we still have so many cases circulating in the community that we're still transmitting it around. So one of the analogies that I've heard is that this pandemic is a bit like a game of dodgeball, right? So if you're in a game of dodgeball and you have 5 balls coming at you, you might get hit, but you might be able to dodge it, right? If you're in a game of dodgeball and you have 50 balls coming at you, it's very unlikely that you're going to be able to dodge it. The vaccination gives you a helmet and some knee pads and some wrist guards, and will protect you from getting seriously hurt and from needing hospitalization from those dodgeballs coming at you. But if there's 50 dodgeballs coming at you, you're still probably going to get hit.
Yeah.
That's why our cases are still so high.
And probably our last question, which you mentioned in passing, but do you know what the progress on getting a vaccination for children below 12 years old is, and when it's likely to be available?
Yeah, ATAGI haven't given us an exact time, but we're thinking, late this year, early next year, we'll have a vaccination for the under 12s, over 6 months, under 12s. The 0 to 6 month age group, I don't think will vaccinate.
Great. And just there's a few questions here about, for example, policy or union or industrial related questions. If you want to send those through to, there's multiple ways to contact us. So 96981400 is our phone number. info@sdavic.org is our email address. And you can also message us on Facebook and Instagram. And if we've missed your question, you can send it through there, and we'll try to get to it. Michael, I might throw to you to close out the evening.
Thanks, Alan. First of all, I'd like to thank the members who joined us for this session tonight. And secondly, I'd like to thank Dr. Lena Rennick for that very good presentation tonight. And I hope people feel that they got information of value out of tonight's presentation. As Alan said, you can contact the union at any time on the industrial issues. Tonight was about the medical issues. So you can contact the union about any of the industrial issues. And we will keep you informed on all the political and industrial developments in relation to this matter. So thanks very much for your contributions tonight. And we'll keep you up to date with whatever information we have available.
Thanks, everyone.